have an amazing group joining from the auditorium. It's kind of a rowdy group here, and we're having a great time. So anyone who would like to, we have some empty seats, just a few left. But if you want to come join us in the auditorium, you're welcome to. That way you actually get to see each other in person. But our grand round speaker today is none other than Dr. Lauren Brooke McGovern. And she is one of our third-year pediatric residents, and she's going to be talking about bridging the urban-rural divide in pediatric care. And I think she's an excellent person to talk about this, since she has a lot of experience with rural health care, graduating from the University of Montana with her Bachelor of Science degree, and then pursuing a special track for medical school, where she worked with underserved rural communities throughout medical school, and was awarded the Gold Humanism Award for her excellent work in those communities. And she also has done some amazing research with a hospitalist group looking at barriers to patient follow-up because of lack of transportation. So welcome, Lauren. Wish you were here with us in the auditorium, but glad to see you on Zoom.
Thank you so much, Dr. Ottolini. Good morning, everyone. I'm going to go ahead and get started. Please feel free to place questions in the chat box. I will likely be able to see them in real time, but regardless, I'm going to do my best to answer your questions after the presentation. So, as far as financial disclosures to make, I have none, so we can move on. Here's a quick outline of what we will discuss during today's talk. First, we'll define what categorizes as rural versus urban. Second, we will review some of the common differences and challenges with urban and rural pediatric care. We'll then focus on some of the specific disparities in aspects of rural care and the various ramifications those have on health outcomes. We will then move on to the rising role of telehealth and how this fits into rural care delivery. And finally, we'll wrap up with looking at how rural health delivery has adapted and how it can improve in the future. We will discuss how we as pediatricians can attempt to equalize, overcome barriers, and close care gaps for rural pediatric patients. So here's the mission statement of the AAP. The mission of the AAP is to attain optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. I know we're all aware of the AAP's mission statement, but I thought it a fitting way to begin this presentation. I want this to be a reminder and backbone of why we all chose to go into pediatrics. This is definitely a broad statement, but these are the goals. These goals are what we seek to accomplish as we move forward in our careers, whether that be urban or rural in our care for children. And so in our discussions today, I want you to keep in mind that we are committed to the health of all children and not just those in our close proximity. I thought it would be helpful to outline some definitions of what classifies as rural versus urban to give structure to our discussion. The majority of literature discussing urban and rural pediatrics looks to the National Survey of Children's Health as a baseline, and this reference will be what I carry from during the bulk of this presentation. This survey provides a unique resource to analyze the health status, healthcare use, activities, as well as family and community environments experienced by children in rural and urban areas. It proved quite helpful in guiding my presentation, as all of the statements and reports were noted only if they were statistically significant. As for definitions, urban areas include any metropolitan area plus their surrounding towns that commuters flow into. Portland, for example, would classify as an urban area. Large rural areas or large towns have populations from 10,000 to 50,000 people. And finally, where I'm planning to work would be classified as a small, isolated rural area. These small towns have populations of 2,500 to about 10,000 people. Of the 74 million children in the US, 6.7 million live in large rural areas, while 6.8 million live in small or isolated rural areas. This is a stark contrast to the 60 million living in urban areas. Another way to look at these statistics is that nearly 1 in 5 children in the US resides in a rural area. I've thrown in a few photos during this presentation of rural places that are quite special to me in hopes of breaking up the talk a little bit. I hope we all recognize Portland on the right of the screen. On the left one, that's one that I'm much more familiar with. That's Livingston, Montana. It's where I grew up, and it's a town of about 3,000 people. It's nestled at the base of 3 mountain ranges and home to the Yellowstone River. So let's first take a look at the specific health risks faced by pediatric patients in rural areas. Children living in rural areas have higher rates of chronic conditions such as obesity, asthma, and diabetes, as well as emotional, behavioral, and developmental conditions. They are more likely to have tobacco exposure and are more likely to rely on Medicaid or public insurance for their health care. They have a higher risk for death from injuries, have overall higher rates of infant mortality, and finally, they are less likely to exercise or use preventative health services, resulting in poorer health statuses overall. All of these things are greatly concerning when we're looking at how we're setting up a whole generation of children to enter into adulthood. Discrepancies in overall health status and health risks may be attributable both to children's geographic locations as well as to the demographic characteristics of those who live in rural areas. First, rural children are more likely to live in poorer families. For families that live in small or isolated rural areas, 23% have household incomes below the federal poverty level. This compares with 17% of urban household incomes below the poverty level. They're also more likely to use tobacco than their urban counterparts. These children experience risks to their educational and social well-being, which, as we all know, can affect their long-term trajectory. They're more likely to repeat a grade and carry a high risk of not graduating high school, resulting in overall lower education levels. One of the larger demographic concerns is a geographic challenge to accessing healthcare. Rural residents report less access to both general and specialty pediatricians. They end up traveling greater distances to use health services, and because of this, experience suboptimal access to care. The reason they must travel these distances is because they live in health professional shortage areas. We will delve into what classifies as a shortage area in the slides to come, but for now, we can recognize that there is both a geographic and a numeric disproportion of care. Given these shortages, they rely more heavily on the emergency department to obtain care. Another contributing factor is insurance. Though the statistics show us that across locations, approximately 90% of children currently have health insurance, rural areas are more likely to have public insurance or inadequate insurance, not covering needed services, or having large out-of-pocket payments. Let's begin to discuss the various health facilities and the challenges of healthcare delivery in these rural areas by looking at what infrastructure is in place for providing care and how it's being used. Of the 2,050 non-metropolitan counties in the US, 1,500 of those are considered medically underserved, and that's a designation that's put in place by the federal government. A further breakdown of these areas are based on health professional shortages. In order to get a designation of a health professional shortage area, it's given when the population to primary care physician ratio is 3,500 patients to one primary care physician. It can also be given if the physicians in the area are unable to serve the designated population. So in returning to our 1,500 county breakdown, 700 were designated shortages for primary care, 460 were shortages for dental care, and 520 had shortages for mental health services. I hope it's starting to become clear why rural residents report less access to general and specialty pediatricians, as well as greater travel time and other assorted barriers to healthcare. Also, many of the rural facilities are greatly underfunded, which affects how they can provide quality pediatric services. Another contributing factor to the usage of services available is the lower health literacy rate. Low health literacy is associated with a decreased likelihood of using preventative health services and overall poorer health outcomes. I wanted to include this slide to discuss the needs of the community from the patient's perspective. There are definitely overlaps with the previous slides, as all of these ideas are obviously intertwined, but I feel like this gives us a slightly different lens to look through. I keep referring to the workforce shortages, so let's look at the distribution of pediatricians. Of all primary care physicians, pediatrics represents the smallest number of specialties located in non-metropolitan areas. Only 11% of board-certified pediatricians practice in rural communities, and they care for 30% of the childhood-aged population that make up these communities. To give that some contrast, 60% of practicing pediatricians in urban areas care for 35% of the urban children. That's a huge difference and quite a reversed ratio. I know we've harped on this already, but the geographic barriers resulting in increased time to healthcare also exacerbate social and economic difficulties experienced by families. So what does this all amount to? What needs do these communities greatly lack? They are in need of not only primary care access, but also mental health care, counseling, chemical dependency programs, OB-GYN for young adults, dental care, and adequate transport and insurance. All of these issues leave large proportions of the population without a regular source of care, a greater incidence of unmanaged chronic conditions, and ultimately an increased incidence of resultant disability. Let's dig a little deeper into why we're seeing these trends. I want to keep the following questions in mind. Why are we seeing these care gaps and different health outcomes? And how can we as pediatricians equalize, overcome barriers, and close care gaps for rural pediatric patients? Once we have some common issues, then we can better target our interventions. It's worth mentioning that many of these issues we have discussed so far are based in social determinants of health. And really, I feel like a full presentation could discuss the impacts of social determinants of health. But given that we only have an hour, I'm going to target this talk to focus on a very narrow window of why we're seeing the outcomes we are and on what we as pediatricians can do to help bridge some of these differences. Okay, quick interlude to remind us of the wonderful side of rural spaces. Here's a photo I took on a hike in Glacier National Park. Let's look at why we continue to struggle with physician shortages. Unique physician hardships exist in rural areas. Providers experience professional isolation, reduced access to medical information and continuing education, and lack of communication with subspecialists and ancillary support services. All of these things make recruiting and retaining physicians in these areas very difficult. Recruitment barriers also include geographic isolation, lack of technologically trained support staff, limited social and cultural activities, limited employment opportunities for spouses, lower salaries, and overall lower quality educational systems with fewer educational choices. We've also seen that fewer students are entering medical school from rural areas, decreasing the likelihood of graduates returning and filling these rural positions. Training flaws also exist, including fewer rural residency programs and an ever-increasing debt load, which can act as a disincentive to enter the primary care field, let alone one in the rural health field. These physicians also experienced increased demands of their time. On top of high patient volumes, they are also expected to care for medically complex patients without the aid of easily accessible subspecialists. They generally cover not only the care of their clinic patients, but also newborns and hospital admissions, and sometimes emergency department coverage as well. Alongside their clinical duties, they're expected to have increased participation in the day-to-day operations of the hospital and clinic, things like participation on committees and oversight groups. All of this leaves them with few opportunities for continuing medical education and staying up on the up-to-date current practices. Going hand in hand with physician shortages is the challenge that rural families then experience having reliable and regular access to primary care. Once again, we see the contributions of geography and relative maldistribution of pediatricians affecting patients' ability to be seen. This, paired with social and economic factors, make it difficult for families to travel to locations where pediatric health services are provided. Rural families are also more likely to have unmet healthcare needs due to transportation difficulties or because care was not available in their area. As for the role insurance plays in the access to primary care, what we see in the literature is that there is an equally underinsured proportion of children in both rural and urban areas, but urban children might be able to obtain many uncovered services from charity clinics or safety net clinics that are not readily available in more rural areas. We also see a lack of access and ease into specialty care, as I had mentioned. Pediatricians working in rural communities report more difficulty accessing subspecialty care compared to other providers. More rural PCPs report high levels of satisfaction with the quality of subspecialty care when it is delivered. However, they were not satisfied with the long wait times for appointments and the overall availability of many pediatric subspecialists. On the whole, there are 40 subspecialists for every 100,000 patients in rural areas versus 134 subspecialists for every 100,000 urban patients. I don't think that any of us find this surprising, as it would be impossible for many subspecialists to have enough volume to sustain a practice in a rural area. That being said, the hurdles to access are increasing in number. Again, insurance can play a significant role. Many PCPs report subspecialists' non-participation in health insurance plans and lack of acceptance of uninsured patients further widen the care gap. Even when studies controlled for insurance type, there were still many unmet needs, such as uncovered services. And once again, distance and isolation present another blockade. Many families, even if the referral is successfully made, are unable to take the time off from work, or they lack transportation to travel to see the subspecialist. Okay, we've talked a good bit about primary care and specialty care referrals, so let's move on now to rural pediatric emergency medicine. Emergency care and the availability of pediatric emergency expertise differs between rural and urban hospitals. Despite these differences, we see that there is a higher utilization and over-reliance on ERs in rural areas. This is likely a reflection of the fact that children with suboptimal access to primary care have been shown to turn more heavily to the emergency department. An ER visit does not necessarily represent compromised access if emergency services are actually required, but the higher utilization of the ED might be a reflection of limited ambulatory care hours requiring an ED visit for a primary care treatable condition. It's also possible that a child who visits the ED in the evening, they might actually see the same provider that they would have seen earlier in the clinic. Obviously, these visits are much more costly in both time and money, which puts families at a further disadvantage. So then, what's happening when these children arrive in rural ERs? What kind of care are they receiving? Optimal emergency care for children may be quite difficult for rural hospitals to provide. They have overall lower visit volumes and are less likely to be teaching hospitals or to have a children's hospital in their county. They're less likely to be level 1 or level 2 trauma centers, and because of these factors, they have less access to pediatric and emergency medicine trained physicians and lack staff well trained in pediatric care skills. Most of these ERs have lower inventory of pediatric emergency supplies, making their job even more difficult. Despite lacking these tools for the job, they may have to receive and stabilize critically ill children prior to transfer. Let's take a look now at hospitalizations of rural children. The data I'm citing on this slide is from reviewing some of the current literature that attempts to describe the clinical demographic and inpatient healthcare services that are characteristic to rural children. Rural kids account for 1 of every 8 pediatric admissions. When hospitalized, they cost more, have longer mean lengths of stay, and are readmitted more often. This is even after controlling for indicators of medical complexity. Hospitalized children from a rural area have a higher prevalence of chronic condition, complex chronic condition, or need for medical technology assistance. Despite a higher prevalence of these characteristics, rural kids are more often discharged to low-income and medically underserved areas that are significantly farther from the hospital. Rural children live between 45 and 110 miles away, while urban children only 5 to 25 miles. After discharge, they have a 10% increased likelihood of 30-day all-cause readmissions. This could imply that the hospital and local healthcare providers lack a working relationship to attain the coordination and integration needed for a safe and reasonable discharge plan. We see that there are limited home and community-based health services available for rural children, and lack of these services increases the burden of caregiving onto the child's family. It's also not a surprise that for rural families in low-income neighborhoods, caring for a recently hospitalized child with chronic illness will likely lead to additional financial stress, especially if they experience higher out-of-pocket costs. As a result, the economically challenged families may experience difficulties adhering to a discharge care plan, especially if the plan that is associated with co-payments for medications, equipment, and urban follow-up visits. All of these things can ultimately lead to readmission. Many researchers are looking to see if the disparities in care we've mentioned still exist, questioning if our medical system has put enough aid and thought into changing these disparities. Unfortunately, the papers all showed that yes, indeed, children in rural areas do still have different access to healthcare, and in turn, it's affecting their health outcomes. In extreme situations, some health outcomes are sadly comparable to those of third world nations. Many of these studies took the time to correct for interventions they thought were particularly helpful. Even when correcting for these interventions, they showed statistically significant disparities still persist, especially for those with special needs. Rural children still have significantly higher rates of unmet medical and dental need, and at least 1 ED visit in the past year. All of this is with adjusting for the child's age, race, ethnicity, household income, parental employment, parent's insurance type, and the child's insurance type. The most likely explanation for persistent access disparities relates to factors influencing the availability of services. The current literature recognizes that it's not possible to offer a wide variety of specialized services in isolated areas, and that the workforce shortages are still contributing to unmet medical and dental needs. In order for us to make a change to the health outcomes of our rural cohorts, we will need to increase access to care in some shape or form. Okay, a quick summary slide to reflect on the themes we've discussed so far. The topics I've listed are all intertwined with each other, leading back to our overall issue of access to care. Now that we have a list of issues, as well as some background information, we can discuss how to target a possible intervention to hopefully alleviate these in the future. The obstacles we've discussed include an overall shortage of general and specialty pediatric care providers, increased difficulties accessing subspecialty care, longer travel times and transportation issues, higher rates of chronic conditions, increased reliance on emergency rooms, lower health literacy, poorer health statuses, and an increased rate of infant mortality. While it's difficult to overcome many of these barriers, there is a growing body of literature that demonstrates that many of these issues can be partly addressed with the use of telemedicine. Another photo. Here's a lovely beach I surfed at while I was in New Zealand. So without further delay, let's talk about the rising role of telehealth and telemedicine. As much as I didn't want to mention COVID during this talk, I do think it's worth recognizing the role this pandemic has had on us, improving our telehealth and telemedicine care. Okay, that's all I have to say about COVID. As I just mentioned, studies are now observing how telemedicine can partly overcome distance, lack of transportation, poverty and unemployment, inadequate health insurance coverage, and shortages of providers. Models of care that use telemedicine can introduce otherwise regionalized pediatric subspecialty expertise into the most remote communities, as well as non-traditional settings such as childcare centers, schools, or the home. Many of the services provided using the telemedicine can simultaneously minimize burdens on parents and other caregivers missing work, children missing school, and the costs and risks associated with travel. The studies I reviewed demonstrated the feasibility and efficiencies gained with different implementations of telehealth. The remainder of this talk will focus on models of care that use telehealth and how they have the potential to address pediatrician geographic misdistribution and disparities in the quality of care provided. Let's first discuss a brief overview of the different types of telemedicine and then move on to focus on successful examples from the medical literature and the potential for telemedicine application. Telemedicine is defined as the use of electronic information and communications technologies to provide and support healthcare when distances separate the participants. The term telemedicine is typically limited to the use of these technologies for delivery of direct patient health services. The term telehealth, while often used interchangeably with telemedicine, is a broader term. It generally includes health information sharing, health profession and patient education, and remote or mobile patient monitoring. Telemedicine generally encompasses three distinct types of applications, including live interactive video conferencing, also called synchronous, store and forward or asynchronous transmission of medical images and information, and finally, remote patient monitoring. Live telemedicine involves real-time, two-way transmission between a patient and provider and is most commonly used for ambulatory subspecialty consultations. Store and forward telemedicine involves a specialist review of a recorded health history with digital images or video. Common examples in pediatrics include the use of teleechocardiography or teledermatology. Remote patient monitoring involves the transmission of personal health and medical information, allowing a provider to track healthcare data such as symptoms, vital signs, or laboratory data. Telehealth is the broader of the two terms and can include a range of health services from education at a distance to clinical diagnosis and treatment. It really is more of an umbrella term. So the applications of telehealth is wide in breadth, and I don't feel the need to read you this slide to convey that. This list does include many of the already studied applications. We'll discuss many of them, but instead of reviewing every study I read, I thought it would be more helpful to have this visual representation of how this body of knowledge is growing. I think it'll be very interesting to see how ambulatory and inpatient newborn care in rural areas will change in the years to come. Okay, this photo is from one of my favorite hikes growing up. The trail starts about 5 miles from the house I grew up in and has some phenomenal trout fishing once you get to the lake. Like any good study, we should prove that telehealth is at least as good, if not better, than what the current standard of care is. The data that has been collected thus far has shown just that. Several studies have demonstrated that by using telemedicine to provide direct patient care or support the care of children allows for delivery that is more consistent with evidence-based guidelines, as well as more appropriate referrals to subspecialists. The outcome for patients aligned closely with outcomes achieved if they had seen the subspecialist in person. Every study I read regarding telehealth commented on high satisfaction rates for both families and providers. Along with satisfaction, there was improved overall quality of care and the ability to provide accurate diagnoses and care plans, all while decreasing costs, decreasing admission rates, and improving overall health outcomes. Telemedicine is taking on an increasing role in addressing the numerous gaps in rural pediatric ambulatory care. It has been successfully used in pediatric subspecialties such as dermatology, otolaryngology, endocrinology, pulmonary medicine, and cardiology, to name a few. These are where they provide consultations virtually in the PCP office, and it's consistently led to strong outcomes. It has reduced the patient costs of healthcare and time related to physician travel, in addition to reducing the time and out-of-pocket expenses for families who may need to travel from remote locations. In many cases, the use of telemedicine in the ambulatory setting has reduced the need for office visits and hospitalizations, decreased the use of emergency departments for non-emergency problems, and increased parent satisfaction, and really has overall enhanced effective population health management. There have also been studies looking at developing teleeducation curriculum intended to optimize the caregiving skills of rural families and rural healthcare providers of children with medical complexity after hospitalizations. These studies are still being conducted, but so far have shown some improvements in rehospitalization rates. The role of telemedicine for subspecialty care definitely ties in well and overlaps significantly with the studies from ambulatory settings. It can enhance access to subspecialty care for children with healthcare needs in rural underserved areas. For example, store and forward and live interactive consultations result in significant changes in diagnosis, treatment plans, and clinical outcomes. One analysis of live interactive teledermatology showed that diagnoses were changed in 70% of patients, and management was changed in 98% of patients. Another study of pediatric otolaryngology showed reduction in costs by 30% when compared to face-to-face visits. A study of a child telepsychiatry reduced outliers in psychotropic medication prescribing and prevented admissions to residential treatment facilities. Clearly, we are going to talk about school-based telemedicine. So here's a picture of the one-room schoolhouse I attended from kindergarten to 8th grade. A few studies have been conducted looking at school-based telehealth as a way to increase access to care. These studies all followed a similar structure, linking a full-time school nurse with a telehealth pediatric consultant, either community pediatrician, resident, or advanced nurse practitioners. They were given access to shared health records, video conferencing, and the use of electronic stethoscopes, otoscopes, and ophthalmoscopes. The studies generally looked at the quality and cost effectiveness of the healthcare provided. The outcomes clearly supported the concept that clinical services for the most common child health problems that present in the school setting can be addressed effectively and satisfactorily with our current telehealth technology. The most common diagnoses were otitis media, pharyngitis, dermatitis, and upper respiratory infections, and providers reported overall high diagnosis confidence scores of 4 to 4.8 on a 5-point scale. Families similarly expressed satisfaction with the care that their children received. 95% of parents said the system prevented an ED or a physician visit. They were also enthused that it avoided a and resulted in significant savings in both work-related costs and direct medical costs. This was part of a study I found extremely encouraging, seeing as many low-income families have significantly limited ability to take time off from work for both financial and job security reasons. As an added bonus, while these visits reduced the financial burden of ED visits for the families, it also reduced the overall cost on the medical system. These studies also show how this model could improve care for children with chronic conditions like type 1 diabetes and asthma. The interventions here included monthly video conferencing between the school nurse and pediatric provider to discuss patient management. These monthly meetings alone resulted in improved hemoglobin A1C, fewer urgent calls for diabetes care, and fewer emergency room visits, as well as hospital admissions. For children with asthma, they showed improved symptom control similar to face-to-face encounters with subspecialists. Overall, the school-based telehealth was a great success and quite easy to implement. As we know, rural areas have fewer physicians, nurses, and specialists, and it's projected that rural workforce shortages will increase even more in the future. This fact alone should be reason enough to provide further workforce development for these providers. Given the lower access to specialists, rural providers perform a higher volume and variety of procedures compared to clinicians in urban areas. Despite their need for broader ranges of competencies, they face several challenges relating to continuing professional development, including travel time, expense, and once again, geographic isolation. The education delivered using telehealth technologies can easily overcome several of these barriers. We're starting to see methods for continuing education through video conferencing with subspecialists, web-based education, and live case conferencing. It's also being used to connect rural clinics and hospitals for collaborative quality improvement and extended educational opportunities, bringing evidence-based guidelines into practice with the rural medical areas. In general, the benefit of using telemedicine is that the pediatric specialists can have a virtual presence at the patient's bedside. They have direct access to patient views, the team of treating providers, the family, as well as monitors and equipment, giving them all the tools they need to assist in providing care. There are plenty of studies looking at various ways to implement a range of these options. So without getting too much into the weeds, I'm going to talk through some of the most helpful and common uses of these modalities. Clinicians caring for children in rural communities often have to make difficult decisions whether or not to admit locally or transfer to a regional pediatric center. In looking at the data, there seems to be a tendency to over-triage and transfer children based on the potential need for special services. This trend leads to costly and lengthy transports, and often, once the child arrives, they don't require specialty care. By using telemedicine, it becomes apparent that caring for less severely ill children in local centers can still result in high quality care with some added benefits, including shorter lengths of stay, less resource utilization, lower costs to the family, maintained high quality of care, and decreased hospital readmission rates. This was attained using programs where pediatric subspecialists provide consultations and supervision of care to the hospitalized children in a variety of clinical scenarios. The oversight provided ranged from simple model of intermittent need-based consults to a model that integrates continuous monitoring and a proactive medical decision-making. In the consult model, subspecialists are able to provide intermittent bedside telemedicine consults to a hospitalized patient, which would or could prompt a variety of clinical interventions, including recommendations on diagnostic studies, medications, or other therapies. Continuous monitoring was also used as an option to fully care for the patients from a distance and make proactive medical decisions rather than recommendations. At any point, these consults could also result in a transfer to a higher level of care if needed. It can be difficult in rural areas to maintain emergency pediatric skills given the low patient volume. While medical simulation allows for repetition of skills, most simulation suites are in teaching hospitals and urban areas. Video conferencing instruction is another valuable technology to provide, and these distance training courses can be quite helpful, but there's also evidence telemedicine-based emergency consults can help in the acute and emergent settings. Only 3% of pediatric intensivists practice in rural areas. This leaves so much need and unsupported emergency room care. The evidence behind using telemedicine to support remote emergency departments was absolutely outstanding. I decided to pull from just a few of the pilot programs, which were completed in Vermont and upstate New York. These programs showed us that using teleconsults for critically ill children who presented to rural ERs resulted in similar diagnoses, treatment plans, and plans for disposition as in-person pediatric consults. More specifically, the consulting intensivist reported it improved patient care 90% of the time and maintained better provider-to-provider communication. Remote providers reported that in using the telehealth consults, they more frequently modified their diagnoses and their therapeutic interventions. They had decreased frequency of medication errors and felt more confident with the care that they provided. Based on what these pilot programs show, I think that pediatric critical care telemedicine can definitely help address not only the disparities in access, but more importantly, the outcomes for these patients, including morbidity and mortality. We all know that regionalized perinatal and neonatal intensive care has been shown to reduce mortality rates, but families also pay a personal cost when their infant is hospitalized far from home for often long periods of time. As telemedicine becomes easier to implement, we can now offer remote access for families to bedside rounds and nursing communication. It may also allow for earlier transfer back to rural step-down nurseries closer to home. Some studies discussed that that telehealth can be used by maternal fetal medicine specialists and neonatologists to direct care of high-risk mothers and fetuses, assist in the monitoring and care of the delivery, and help in the immediate management of newborns. Remote management reduced the need for in-person visits by nearly 50%. It allowed for remote prenatal counseling and successfully reduced the number of very low birth weight births, as well as decreased infant mortality rates in rural areas. Neonatal resuscitations can also benefit from these technologies. Generally, rural resuscitations are attended by general pediatricians or family practitioners, while telemedicine-supported NRP training results in comparable gains in knowledge and skills. The difficulty is that knowledge and technical competency rates decline within 6 months if the skills are not used frequently. Instead, telemedicine units in the delivery room can provide immediate, direct access to skilled resuscitators if they are needed, allowing for maintaining a calmer environment, reduced time to transfer, and initiating therapeutic hypothermia when needed. Another implementation can be with failed CCHD screens. If there's no neonatally trained echo techs available, asynchronous or concurrent viewing of echo images from the remote center can improve diagnostic accuracy and generally avoid transfer of care. Finally, there is documented unmet need for lactation support, and telelactation has the potential to increase access and improve convenience for breastfeeding moms. They can connect women with remotely located lactation consultants via their own personal devices without these women needing to leave the home or travel with their newborn. As a final point to conclude our discussion today, I thought it would be appropriate to look quickly at one of the avenues Maine Health is employing for telehealth. This model encompasses provider education and case reviews as opposed to direct patient care. Project ECHO, which stands for Extension of Community Healthcare Outcomes, was formed to employ telemedicine more broadly and to enhance chronic disease management. This model uses technology to link expert specialist teams at an academic hub with primary care clinicians in local communities. Weekly tele-echo clinics combine patient case presentations with mentoring to elevate the level of care provided in remote areas. The general goals that are outlined by Project ECHO include sharing best practices, sharing knowledge and information, decreasing unnecessary referrals, and providing more educational opportunities overall. All of this with the goal of improving patient outcomes, improving communication, and providing more consistent delivery of care and treatment for children across the state. Maine Health is already in the process of expanding our Project ECHO programs for pediatric care. Noah Hoffman is the clinical leader, and I'm sure he can speak more to this if anyone has any questions regarding it. So as we wrap up this talk, there's a few things I'd like you to walk away with. I hope I've illustrated that delivering high quality care and changing health outcomes for children living in rural areas can be extremely challenging. Currently, rural children experience worse health outcomes, and we have discussed today why we are seeing some of those discrepancies, though, and that's through regionalization of care as well as geographic and demographic risk factors. There are significant benefits to telehealth. We can help provide high quality and cost-effective care consistent with evidence-based guidelines. In doing this, we can equalize care, address and overcome a multitude of health disparities, and most importantly, close care gaps, including decreased mortality rates and improved pediatric health outcomes across the board. So where do we go from here? The purpose of this Grand Rounds was to provoke thought, begin dialogue, and hopefully to initiate some positive changes. I believe that we can better optimize and evaluate our pediatric care system to improve outcomes, reduce waste, and improve the patient experience for rural children. Of course, there's a multitude of other possible interventions to help bridge the divide of rural and pediatric care, and we've only shed light on one possible option today. So regardless of what specialty we all end up in, I hope that you remember the difficulties and barriers our rural families and practitioners experience in attaining equal health outcomes for these patients. I want you to all go back to the AAP mission statement and analyze how you in an academic center can better provide care for all pediatric patients. And with that, I wanted to take a moment to say thank you to everyone who helped me not only with this Grand Rounds, but for helping me get to third year of residency. This presentation wouldn't have come together as I had hoped without the help of Tom Reynolds, Pam Dietz, and our chief resident, Carolyn Ranton. I also wanted to thank all of my co-residents. You all are so amazing, and I'm continuously impressed by all that you're achieving and thankful that I get to train with you. Thank you to Brian and Kelly for continuously being patient with my ability to answer emails in a timely fashion. And finally, a huge thank you to my wonderful husband, Duncan. Your patience and support is absolutely unending, and I can't tell you how grateful I am that you are my partner. I know I can't thank everyone and that I want to, but just know you all mean a lot to me, and I'm reminded daily of how lucky I am to have your support. So thank you. Here are my references. And are there any questions? Let's see if I can open up this chat box.
Lauren, I just wanted to thank you very much. This was just an excellent talk and very inspiring, and I hope that we can implement a lot of the telemedicine innovations that you've talked about. We have people who are very interested in a number of those areas, particularly with intensive care and with asynchronous telemedicine through our clinical transformation project, which is doing e-consults through Project Core. So thank you so much. And I think I'll try to field any questions that are here from the audience in the auditorium if you want to handle the chat.
Yeah, if you want to pull someone up, I'll see if I can look through the chat really quickly.
I'm looking at the chat now. I don't see any questions, just a lot of kudos. There is one question. Does funding for critical access hospitals apply to outpatient providers?
I didn't look at the data to look at those two things separately, so I can't speak to that, but I could definitely look it up and find out.
And then I think there's another question from Dr. Miller about how would you propose to balance the role of public health and regional departments of health versus individual healthcare organizations and institutions in pushing telehealth and outreach strategies?
Oh, wow. That's a huge question. I only read one article discussing some of these policies. Dr. Miller, I can send you the article that I read about, but I don't feel like I have a good enough answer to answer you in a clear way right now.
And I think another question was, is there any evidence that I think it means specialists going out to a satellite office in the community is better than telehealth?
So those studies, there was a few that looked at the variations there, but the cost of sending the physician to those satellite areas actually was more than setting up a telehealth communication, and the outcomes were pretty similar. So I didn't talk about that too much, but I did read about it, yeah.
And I think there's another question from Dr. Olshan, who's actually leading the ECHO this month. And his question is, how can we motivate pediatricians to provide clinical questions when presenting for Project Echo? Because I think that's a challenge, trying to get the community providers to submit their questions.
Oh, okay. Well, I think posing it to them as an opportunity for more support in their care might be a good way to start. You know, a lot of us go out into rural practice expecting to be on our own, and we don't always have in the forefront of our mind that we should be jotting down these questions that we have. So I think posing it in a different frame of reference might help those providers come to you with the questions.
All right, any questions from anyone here in the auditorium? Are you guys feeling prepared to go out and practice telemedicine, or what concerns do you have about how we can enhance your training in that way?
So if you had asked me that before the pandemic, I would say that I have very little knowledge of how telemedicine works and how to make it feasibly an option for families and for different rural communities. But now that we are a few months into this pandemic, I feel like our time in clinic doing rural telehealth medicine for these families into their living rooms, into the schools, however we can get in touch with the families, I feel like I'm way more prepared to do that, especially now that the pandemic has happened. I can't speak to how other rural training or how other pediatric training programs have taught this, but I feel like we've learned the billing, we've learned the technical aspect, and the thing that we might struggle with is we haven't really used the electronic capacities that are available to us, like listening with an electronic stethoscope, looking with electronic otoscopes, relying on those technological things to enhance our care. But I feel like those are minor details compared to the backbone of how do we run a telemedicine clinic.
Great. Well, thanks again, Lauren, and we look to you for your ideas and leadership in moving us forward in bridging our urban-rural divide here in Maine. Thanks so much.
Thank you so much, Dr. Olini.
There's lots of applause for you here in the auditorium.
Thank you.